A 10-year-old child presents with leg pain and fever. I am showing you the radiograph of the lower leg. Describe the findings.
All right, let's take a look. The radiograph of the lower leg demonstrates a mostly sclerotic, aggressive bone lesion arising in the diaphysis of the proximal fibula. The lesion has an ill-defined margin and a wide zone of transition merging imperceptibly with normal bone. Importantly, there is a florid, spiculated periosteal reaction with a prominent hair-on-end appearance surrounding the fibular shaft. The growth plates are open, indicating a skeletally immature pediatric patient. The highly aggressive diaphyseal features in a child are highly suspicious for a primary bone malignancy, specifically Ewing sarcoma.
What is the differential diagnosis for an aggressive focal bone lesion in a child, and how do we differentiate the two most common primary bone tumors?
The primary differential diagnosis for an aggressive focal bone lesion in a pediatric patient includes Ewing sarcoma, osteosarcoma, and acute osteomyelitis. To differentiate the two main malignancies, we evaluate the patient's age, lesion location, and radiological appearance. Ewing sarcoma is most common in younger children, has a diaphyseal predilection, is typically permeative or lytic, and metastasizes to other bones. Osteosarcoma typically affects older children and young adults, is located in the metaphysis, appears more osteoblastic or sclerotic, and metastasizes to the lungs.
I'm showing you a comparison knee radiograph. Describe its findings and the diagnosis.
The comparison anteroposterior radiograph of the knee in a 12-year-old child shows an aggressive, dense sclerotic lesion in the distal femoral metadiaphysis. This lesion has a wide zone of transition, cortical breakthrough, and a prominent sunburst pattern of aggressive periosteal reaction. There is also elevation of the periosteum at the proximal margin, representing a Codman's triangle. This represents a histologically proven osteosarcoma, illustrating the classic metaphyseal and osteoblastic features compared to the diaphyseal Ewing sarcoma.
Describe the pathogenesis, clinical features, and histology of Ewing sarcoma.
Ewing sarcoma is a highly malignant small round blue cell tumor closely related to primitive neuroectodermal tumors, or PNET. It has a peak incidence at 15 years of age and shows a strong Caucasian predilection and a male-to-female ratio of 1.2 to 1. Clinically, patients present with severe progressive bone pain, local swelling, and systemic signs like fever, weight loss, and leukocytosis. This systemic presentation can easily mimic acute osteomyelitis, which also presents with diaphyseal bone destruction and periosteal reaction.
Discuss the management, local and systemic staging, and how you would manage this patient as a radiologist.
The patient must immediately be referred to a specialized orthopedic oncology unit for multidisciplinary management. Further imaging includes a dedicated MRI of the affected extremity to assess intraosseous extension and soft tissue involvement for surgical planning. Systemic staging is performed with chest CT, a whole-body bone scan, or PET CT to look for pulmonary and osseous metastases. As a radiologist, I would immediately call the referring pediatrician, recommend urgent MRI and staging, and advise against any local biopsy outside of a specialist bone tumor center.